Good morning, ladies and gentlemen. Good morning, Chairperson, my co-chair, co-panelists. Thank you very much, organizers, for having invited me. I was a little surprised to have been invited to this summit from Jaipur, Rajasthan. I was just thinking loud what was the great reason for spotting me, because I am a clinician. Almost 95%. 5% I am dealing in admin because of compulsive reasons, because our own promoted hospital. But I am an intensivist. I have been involved with development, promotion and research in critical care medicine. I have been involved in promotion of 2 hospitals in Rajasthan, Jaipur. And I had requested the organizers to give me 20 minutes if the chairperson permits me. This is the hospital where I work, and this is the ICU. I wanted to show you this ICU picture because we have 1 nurse, 1 patient ratio in our ICU, which converts into efficiency. It is 1.5-year hospital. It is focused on trauma and critical care medicine. This is another slide I wanted to show you. Just multi-organ failure syndrome. First 500 cases in last 24 months. International mortality is reported at around 40%. Indian mortality is 65%. Our mortality in first 500 cases has been less than internationally reported. It will go up because we have been quite excited, enthusiastic. It's a new hospital. We do not have hospital-associated infection, but it will go on. But I'm sure it will be much below the reported Indian and accepted Indian mortality of 65. It should be somewhere around 45, 46. Most of you, I'm sure, are administrators, hospital promoters. There may be few conflicts because I'll be talking hardcore clinician's view of efficiency in critical care medicine. And I am a full-time intensivist, a part-time administrator. I've been promoter of critical care medicine in this country for last 10 years. I've been president of Indian Society of Critical Care Medicine. And I've been the chair of the guidelines committee of Indian Society of Critical Care Medicine, which formed guidelines for planning and designing ICUs in India. And I have lots of chapters in many textbooks on chapters on ICU designing and planning, mostly from clinical point of view. So there will be maybe some few conflicting opinions and expectations from my side. Ladies and gentlemen, over the last 1 decade, healthcare is becoming transparent and customer-oriented. Patients and their relatives have the right to know the standard of care and its costs. We know that now, with so much of spending and marketing, quality of service offered has to be of high standards. Result of intervention and treatment have to be generally told to them in advance, forecasted in a way. A little bit of astrology is involved. My patient coming with multi-organ failure, and I have to tell my patients whether he is going to survive, what is the chance, 40%, 50%, 60%. And it is with great difficulty that we also have to make them aware and accommodate with us a possible undesirable outcome right in the beginning when we start treating them. This change has required the healthcare provider to be efficient and prudent in management of services and delivery of healthcare. What is operational efficiency in ICU? To my mind, operational efficiency of any healthcare unit is judged by its quality indicators. It is particularly more relevant in ICU because of the high cost and mortality involved. Therefore, we have to depend on quality indicators, which are very, very important. And the basic philosophy which can maintain these indicators will depend upon how much standardizations we are able to develop. That means the standard deviation has to be constant, it has to go down rather than go up, and the pendulum should not move too much between the lows and the highs. There should be a continuous zeal for improvement of those standard procedures and processes, and there should be a gradual bettering of the parameters which have been achieved earlier. And anything which brings down those standards should be strictly opposed to and prevented. And the last but not the least is innovation. Innovation is the need of the hour, and who will do the innovation? The man on the field, the leader in the field. The leadership has to take the responsibility of innovating, finding new ideas. Our Prime Minister has said, give me ideas. You know, unless the leader gets ideas from the field, we cannot innovate. And if we cannot innovate, our standard deviation will move too much, because it cannot stay stationary at one place. Either it has to improve or it has to deteriorate. So if we do not innovate, if we do not improve, then it must deteriorate. That must be prevented. Standardization has to be achieved by the unit or the team ICU which works in the field in the ICU. They have to maintain the standards. They have to achieve the standard deviation within the control. Innovation mainly has to be motivated by the leadership. Leadership of the organization, leadership of the unit, leadership of the nursing team, leadership of the other paramedical, including the class, what we call as the housekeeping force, even the cleaning team, or even the clerical team who are working on the computers. They let us know, sir, why don't we put these data in this particular manner? It will be very, very difficult to retrieve this data, and this becomes very, very rewarding. So we must encourage innovation and improvement all the time at all levels. As a clinician, I have always felt that what is operational efficiency in ICU? Whatever occupancy, whatever revenue your ICU may be generating for the administrators and for the balance sheet purposes, it will largely depend upon the outcome, whether the patient is surviving, coming out of the ICU healthy, the ICU stay of the patient, what we call as length of stay in the ICU, satisfaction of the doctors and the staff is very, very important. If they are not satisfied, they will not stay there. There will be high traffic. Burnout of the doctors and staff has been a problem in ICU all over the world, and this is particularly getting worse in India because of rapid development of healthcare delivery and development of corporate sector hospitals, and ICU are very, very high on their priority list, and they take away doctors, the duty doctors, the nurses from everywhere, anywhere. So if you want to retain your best doctors and nurses, their satisfaction and preventing their burnout is very, very important. Patient relative satisfaction, most of us agree, there is no controversy about that. I will not dwell on that. Key performance indicators is the term used mostly by administrators, and so therefore I have to discuss this particular subject. This has not been developed in India, unfortunately. This has been developed in Western countries. They have practiced it. We are trying to adopt it, but unfortunately we have very seriously failed in adopting and tuning our system to these KPIs. We depend on these indicators at least only for theoretical consideration. We have not been able to transfer them into our practice. Hardly any institution has implemented them in letter and spirit. There may be one odd exception somewhere, somehow, but I am not very sure. Monitoring the outcome through quality indicators it has not been institutionalized. Major reason appears to be the fact that majority of ICUs in India are being run as open or semi-open, closed, semi-closed ICUs with unaccountable custodians. It doesn't belong to anybody. The accounts department is interested in revenue. The administrators are interested in occupancy. The doctor is interested in 8 hours duty. The clinician is interested in his patient surviving. Whatever he has to do, whether it is ethical or non-ethical, 3 antibiotics, 5 antibiotics, 6 antibiotics, doesn't matter. So we have not been able to, and this open or semi-open ICU system has been the Waterloo of our critical care medicine system. These parameters should be put in place and audited at predetermined intervals if we want to practice them and adopt them. This will give us a strong and valid information about efficiency of our system. The need is on the ascend. It should be mandatory for an institution to have these indicators, then compare their performance level with national standard and international standards, use this data to improve quality through standardization processes. Now, what are the key indicator parameters? I have chosen only few which are practicable, which we can put into practice in routine. Mortality, the SMR which we call, morbidity, mainly the most important one is iatrogenic pneumothorax, which we induce while putting in central lines, while we ventilating patients. This is a very, very common complication that develop in ICUs, which can be prevented by prudent methodology and protocols. Decubitus ulcers, just turning the patient left and right, right or left at regular intervals is a small effort on the part of the nurse or the doctor or the attendant who is attending, and incidence of acute kidney injury by prudent actions, or not using nephrotoxic drugs in patients who are predisposed to. These are, very common problems, and we just cannot help these patients. The prognosis of a patient who had come with about 70% survival chances, if he develops acute kidney injury after hospitalization in ICU, his prognosis suddenly halves in a matter of 24 hours after hospitalization, just because we have done a contrast media examination without having fully rehydrated the patient. We have used aminoglycosides in heavy doses. We have given a few doses of vancomycin to these patients without realizing this patient has been exposed to a possibility of acute kidney injury. Operational parameters like length of stay, readmission rate into ICU. The patient is transferred from the ICU to the floors prematurely by the clinicians who are not well versed with the prognosis of these patients, and when these patients should be transferred into the ICU or out of the ICU, because it's an open ICU, because the patient belongs to them. It doesn't belong to the ICU team. The administrator is dependent on the volume that is faced by these clinicians into the hospitals and into the ICUs. So they are the masters, and they move the patient in, they move the patient out of the ICU. They do not respect the views of the ICU team, and the result is premature transfer, and the patient has to be rebrought to the ICU, and the prognosis of these patients go down by almost 75%. Incidence of errors either by omission or commission. This has to be a regular exercise. If you drive, you will have accident. If you swim, you will have drowning. But that doesn't mean that if we practice medicine, we will continue to commit errors. We should prepare the list of errors committed in last 3 months and brainstorm them and bring them down one by one. The target should be set every quarter of the year, and these errors have to be brought down. Errors in the ICU, these are very small things. Fall of the patient from the bed, medication error, one medicine wrongly read for another, adverse events or error rate, needle stick injury, re-intubation rate. Again, because the clinician is not an intensive, he doesn't know, he wants his patient to be extubated as early as possible. He thinks that the intensive care team is unnecessarily ventilating the patient, it can be extubated, or he doesn't agree to the idea of tracheostomizing these patients, and they are extubated prematurely only to have to be re-intubated. Again, the prognosis of these patients goes down, their length of stay in the ICU is enhanced, they are subjected to infections. Nosocomial infection, we've been talking about hospital associated, and this is a huge problem. This is ubiquitous, and unless we deal with it with high hand and with a stick, if I may say so, we are going to have a very difficult times ahead of us. We do not have antibiotics in our bag. We do not have systems and methods to control this. There are very simple ways and means we can control these nosocomial infection. Approximately 1.7 million infections and almost 1 lakh deaths in the United States. Ours is unaccounted number of deaths because of nosocomial infection. Whatever we say, whatever we mention is the iceberg of the real problem. The 3 most commonly monitored variables in ICU are VAP, ventilated associated pneumonias, bloodstream infections, urinary tract infection. Because of very casual way the central lines are put, very casual way the urinary catheters are put, in very casual way the endotracheal intubation is done by the duty doctors or the anesthetist when the patient comes, because everybody is in hurry, patient is critical. Each one of these is a complete surgical procedure and should be practiced as if a big surgery is being done in an operation theater. Unless we imply that in our ICUs, this problem is going only to further proliferate. Human resource, if you want efficiency, should be adequate, competent, motivated and satisfied. Motivated and satisfied is very, very important. Even if you have a lesser number, if they are motivated and satisfied, they should be monitored. Low attrition rate, this may be achieved through innovation, automation, motivation, opportunity creation and burnout prevention. Opportunity creation, I have observed during my last 20 years work in ICU, keeps your younger residents and experienced nurses with you even at a cost of higher salaries. They sacrifice higher salaries, measure attractive destinations if they are motivated in terms of opportunity creations, which may be in terms of becoming a teacher, becoming a researcher, have additional empowerment that will help their retention in the organization. Other factors may be fair equipmentation of the ICU. You should decide whether you want level 1, level 2, level 3 ICUs. Bed doctor ratio, bed nurse ratio, protection from emotionally charged crowds, sufficient in rural areas of the country, emotionally charged crowds, still, sometimes manhandle ICU doctors and nurses. That has to be prevented. Sufficient vacations for the staff, empowerment of the staff and doctors, regular updates, CMEs encouraged. I've noted that if you organize regular updates, CMEs, research programs, allow them to speak, allow them to present presentation, encourage them to visit during the conferences, other stations, that will help their retention and motivate them to work with you. Customer satisfaction, you are better versed with it, how to satisfy your clients and customers, so I'm not going to elaborate on that. But 2-3 slides on open care system. Is the ownership of the patient rather than professional competency of the doctor, which has allowed incompetent doctors to handle ICU patients. Even now, in large number, in almost every hospital of any repute. The institutions generally have lacked courage to annoy patients fetching and owning doctors. They have been generally welcome to treat independently in ICU, and ICU doctors and in charges and directors have been asked to hold on and not to confront these doctors to treat their patients with whatever medication protocols, good or bad, right or wrong. This has highly compromised outcome and efficiency in our ICUs. Competency in critical care has been badly compromised to justify open care system. This is not an India-specific story. This is prevalent in quite few countries, including the United States. This reduces efficiency of ICU as much as 50%. Some government institutions have been able to stop the open ICU cares in India. Studies have clearly shown that the closed system outcomes may be positive by as much as 40%. The prognosis, the survival of the patients have been noted to enhance and augment by as much as 40% if the patients are managed by a closed team. Just 2 minutes, sir. Critical care requires focused 24/7 attention by single team, by a single leader. Non-intensives are not well versed with recent advances in ICU protocols and techniques because they are very busy with their outdoor patients, family practice, and techniques though they may be master of their own subject. Inadequate fluid therapy, inappropriate delayed antibiotic therapy, delayed ICU transfer and premature transfer from the ICU have been the major issue which have come in way of outcomes. Infection control measures have never been their passion. Their poor availability in times of crisis has been a major issue all the time. The visiting physician has got a tendency to treat in ICU in charges as their support staff only and not treat them as their colleague. This invites conflicts and demotivation. Some of the ICU specific modalities like ventilation, CRRT, plasmapheresis has never been their forte. Therefore, empowerment of the intensivist and his team is a major issue to augment efficiency of the hospital in terms of ICU patients. This is like allowing a general surgeon to do neurosurgery, which they used to do when there were no neurosurgeons. So similarly, now you are allowing general physician or internist or respiratory doctors to do intensive care when the intensive care specialists are available. Part-time anesthetists or physician intensivists are not appropriate for full-time ICU management. Time is not too far away when patients' relatives will start asking at the very entry of the hospital, do you have closed care system? Otherwise, they will walk away from your hospitals. This is already being reported from countries like United States because the open care system is quite prevalent there even as of now. So I am concluding standard planning and designing of the ICU is recommended. There should be optimum equipmentation, regular standardization, improvement and innovations. Standard key parameters should be observed. A sustained campaign must be started to implement closed ICU care if our ICUs have to deliver good results at par with Western countries and at par with expectation of our patients and their relatives. Thank you very much, Mr. Chairperson and ladies and gentlemen.